Hi, this is Dr. Purcell. Let's do a quick overview of our coagulation modifiers. Coagulation modifiers are drugs that affect coagulation and are some of the most dangerous drugs used today. Please have an appreciation for these drugs beyond your regular careful, safe administration of medication. They are very dangerous drugs. Numerous factors can affect their action. And among those numerous factors are the numerous other drugs with which they can interact, and even the over-the-counter herbal preparations with which they can interact. So always, always do a medication reconciliation on your patient who's on one of these drugs, and always look up those drugs for synergistic or even antagonistic factors that can change the way the anticoagulant is working. So we have anticoagulants and we have antiplatelets when we talk about coagulation modifier drugs. So this is a little bit of terminology. An anticoagulant is something that inhibits the action or the formation of the clotting factors. They prevent clots from forming. These are drugs like heparin, warfarin, rivaroxaban, and dabigatran. We have our antiplatelet drugs that actually work on the platelet. The anticoagulants work in the coagulation cascade. The antiplatelet drugs do not affect coagulation that way. They affect the platelet. They prevent platelet plugging, and that's our aspirin and clopidogrel. So these drugs are also known as antithrombotic drugs. And do you know what they're not known as? Blood thinners. Take the phrase now from your brain and throw it out the window. These are not blood thinners, and it is a misnomer that people say they're on a blood thinner and they think that their blood's thin and that, it's all watery and thin. It completely is contrary to how these things work. So please don't ever call them blood thinners in my presence. I can give you a hint and tell you Dr. Moon will not appreciate it either, nor would Mrs. Girardi or Dr. Brown or pretty much most of your faculty. So you can call them antithrombotics or anticoagulants. They have no direct effect on a blood clot that is already formed. Those are going to be our thrombolytics that we use. That's a whole different category of coagulation modifying drug. But they can help keep a clot from getting any bigger once we know of its existence, which is how they prevent intravascular thrombosis. They can keep it from even happening at all, or prevent further thrombosis intravascularly. And so that would be a method of prevention. We also use them, to help prevent clots and to help prevent embolus. So once somebody has a clot, we don't want the pieces, the little thrombi to come off and form an embolus and possibly go to the lungs, the heart, or the brain. So that's why we would put patients on these drugs. So their mechanism of action varies depending on the drug. And I can go right back up here. I said we have heparin, warfarin, rivaroxaban, dabigatran, we have aspirin, and we have clopidogrel. All those drugs, and their mechanism of action varies depending on which drug they are. And I'm not going to expect that you know exactly where in the clotting cascade they work, but I want you to understand whether they have a broad work on the cascade or a narrow focus on the cascade, because it makes a difference. The more narrow focused that drug is, the more reliable it is, the less side effects it'll have, the less chance of bleeding that we'll have, and the less we need to monitor. For our older drugs that were developed and have a lot of action within the clotting cascade, they work on a lot of different places. We have to monitor those very carefully. We have to change their doses pretty frequently based on what we're seeing in their labs. And the risk for an adverse bleeding event is much higher. So that mechanism of action is going to vary. They work on different points in the clotting cascade, as I just described. I don't expect you to know exactly what points they're working on. I expect you to understand what that means for the drug that you're administering. They prevent intravascular thrombosis, and they do not lyse existing clots. Let's put up a few different images of the coagulation cascade to help you remember how vast it is. And there's an intrinsic and an extrinsic, and then they come together. And I suppose you learned about this in your anatomy physiology class or even in pathophysiology about this clotting cascade. But just remember, some of these drugs are going to work in multiple points along the way, and some are going to have a very narrow focus, as I just mentioned in the slide previous. So who would not get an anticoagulant? What would be a contraindication that you are not going to give an anticoagulant to somebody? Well, a drug allergy. That's always. I'm just, let's just always put that one out there. So next, anyone who is acutely bleeding or has a high risk for such an occurrence. And now you might say, well, that's duh, of course, but perhaps the person is admitted with a need to have surgery, and they're also, or no, it might be, it's some other reason, but one of their home drugs is an anticoagulant because we have oral anticoagulant agents. And that's on their pharmacology profile. They're for drugs that they take at home, and the physician just copied them all over and ordered them all to be given inpatient. But yet this person's in with a bleeding event. You seeing that on their profile would need to contact the provider and say, I'm not going to give this. This is not safe right now. They'd say, oh, thank you for calling. But that would be someone who does not get the heparin or any of the other drugs. Pregnant women, no, this especially warfarin is contraindicated in pregnancy. Some of the others have a little bit more safety, and women who are pregnant do develop deep vein thrombosis or venous thromboembolism and have to go on an anticoagulant. And there are some that are safer. And you know why they're safer? Let's look here. Because they work in a very specific area of the coagulation pathway and don't affect all this other stuff, so that their safety profile is much better rather than like warfarin that works in all these different places and the risk for bleeding is much higher. Low molecular weight heparins are contraindicated in patients that have an indwelling epidural catheter. So somebody that might have that is someone who's post-pregnancy, post-labor, postpartum, or somebody who had a spinal surgery. We have discovered that when we give enoxaparin, so what happens is somebody that has an indwelling epidural catheter is usually on bed rest because their lower extremities are going to be numb or close to numb, and we don't want them getting up and dislodging the epidural catheter. So they are not up and moving. So then we worry about venous thromboembolism or deep vein thrombosis. So we put them on enoxaparin to help prevent that. And what we have discovered is that the people who we give this to that have epidural catheters can develop an epidural hematoma, which then puts pressure on the spinal cord and can stop blood flow from the upper part of the body to the lower part of the body, or compress nerves and cause nerve damage. So anyone that has an epidural, we need to do passive range of motion, put on their sequential compression devices, etc. The adverse effect, the biggest one, the only one you really need to know with anticoagulants is bleeding. And the higher we go on the dosages, the higher the risk for bleeding. Now, bleeding you may not think is really that big of a deal as long as it's not from an artery, but I'm not talking about bleeding that's localized. Localized bleeding, we can put pressure on and we see it, the patient feels blood running down and realizes something's going on, we put pressure and whatever. It's the systemic bleeding that is internal, that is in the brain or in the GI tract that we don't know that it's happening, and that can lead to a stroke. It can lead to a massive GI bleed and hypovolemic shock. So you'll be monitoring for signs of those things that could be happening. The other things that can happen here, the heparin-induced thrombocytopenia is a possibility. You need to monitor and watch for a drop in platelets when you're giving heparin at a therapeutic level. That could indicate hit heparin-induced thrombocytopenia. The others listed there, not even worried about, because we're more concerned about the reason why we have them on the anticoagulant and the fact that they could have systemic bleeding. So patient education around anticoagulants. Well, the importance of regular laboratory testing, especially for those drugs that require it. The newer oral agents probably won't require it. They'll see their doctor maybe every 6 months to a year for that. Signs of abnormal bleeding. Now, one of the things you'll want to tell them is, if you cut yourself, you're probably going to have to hold pressure longer and expect that there's going to be more bleeding. And it does happen. But the abnormal bleeding is this, you teach them to report blood in the urine, blood in their stool, excessive bleeding of the gums, especially if it's like spontaneous. It's not just from brushing. Um, how do you prevent bruising and tissue injury? And bruising can happen just from lightly bumping their arm or their leg onto something. And bruises don't cause damage. They're not a problem, but they can be unsightly and the person can feel body image disturbance because of it. So, talk to them about how to prevent that and how to prevent bleeding. Let's not be using the chainsaw when you're on clopidogrel. Let's let someone else use the chainsaw. Things like that, because if you do cut something deeply and it starts to bleed, you may actually have a real problem. They should wear a medical alert bracelet indicating that they're on an anticoagulant. Now, foods high in vitamin K do not have to be avoided, but they need to be regulated. They need to keep a regular intake and not just suddenly have like a whole bunch because it's Thanksgiving and the whole week they're eating a whole bunch of greens and other good foods high in vitamin K, and then they don't have any more for a while. That's going to mess with their labs, and that is kind of explained in your book a little bit more. You need to be aware of what foods are high in vitamin K so that you know what foods you're talking about with your patient or your client. And then we want to teach the patient to always consult their provider, their prescriber, before they take any other drugs, even over the counter products, including herbals. That's a big teaching point for people who are on anticoagulation therapy. There's a lot of interactions that can happen. I don't expect you to memorize all the interactions. I expect you to know that you need to tell them, you always call us before you take anything. And generally, in the doctor's offices where they do a lot of coagulation modification, they have patient teaching forms and sheets that they give and say, do not take these over the counter things. Take these. These are okay. These are not okay. And call us before you take these. But you need to be able to tell them that. And then we always monitor for therapeutic effect. If you have someone has a headache and you give them some acetaminophen, you monitor to see if the acetaminophen was therapeutic and took away the headache. So you give an anticoagulant or you're administering an anticoagulant continuous IV therapy. How do you know you're getting a therapeutic effect? Well, that depends on the purpose of therapy. And these are used to prevent and these are used to treat. So depending on that, you'll know if they're getting a therapeutic effect or not. But primarily, you're going to have somebody who doesn't get any clots or thromboemboli. There's no growth in an existing clot. For instance, a deep vein thrombosis doesn't get bigger and bigger and worsen. And then they don't have events related to thrombotic emboli. They may have atrial fibrillation, and so they're on anticoagulation, but they don't have a stroke or they don't have an MI, which is signs that they are getting the therapeutic benefit of the drug. So that is our coagulation modifying pharmacology in a nutshell. And I do hope that this was helpful for you, and I wish you happy studying.